Okay, so this is my first attempt at doing a vlog in the car, but I thought I would talk a little bit about week 1 in geriatrics. So what it's like to be in geriatrics as a medical student. Well, I can remember pretty clearly on Monday, day 1, 8 a.m, just walking in and straight away having this angry old lady look at me and say, "What are you doing in my home? What are you doing in my home? Get out of my home." And then the very kind nurse tried to reorient her and bring her back to her bed. And obviously that's delirium or, progressive, or dementia, depending on what the story is. And then we started our ward round. The common things you see in geriatrics are things like falls, confusion, infections, broken bones, especially broken hips after falls because they're confused, for example, maybe due to an infection. So it's geared towards those sorts of things. And it's pretty hard as a medical student because it's probably hard for any new person to the team because you don't know much about the people who are in the ward and their backstories, but you really need to have a good psychosocial understanding of these people. What was their home like? Where did they come from? What are their homes like? Do they have support? Are there lots of stairs? Things like that. And also you have to think about, can they go back to home? Or are they going to need, respite or rehabilitation or a nursing home? You have to think about when to treat, and sometimes you have to think about when not to treat. In fact, often you have to think about that and have very tough discussions with the family about prognosis. There are a lot of sad moments where people have that realization that this problem they have is now their new reality. It isn't fixable. So for example, this is the story of a 91-year-old man who, we'll call him Mr. G. Mr. G is old, he's skinny, but he lives on top of a pub. He's so kind and warm. And he's living on top of the pub with 5 other mates who live at the top of the pub. And really the pub manager takes care of him, which is so nice. One of the very good reasons to have pubs in Australia. And unfortunately, for the last couple of months, he's been incontinent, so he's weeing everywhere. He can't control it. While he's walking down the hallway, he'll wee, and it's gotten out of hand. And unfortunately, the manager of the pub said it's just not safe for him to be there. He's going to have a slip and fall. It's not hygienic. They can't clean him. He has no family, no next of kin, no kids, no wife or partner, and so he's in a pickle. So he came in so that we could try and sort out the urinary incontinence, and it looks like it's secondary to it's basically spinal canal stenosis. So this is age-related change of the spine. It's getting kind of arthritic and clunky and big, and it's pressing on his spinal cord, making the nerves not work correctly, including the nerves to his bladder, which means he can't hold on to urine. That's why he wheezes everywhere. He also gets the nerves to his hands are getting affected, so he has the feeling that he's got pebbles in. That's what he says. I've got pebbles in my hand, and he can't use his hands well. And that's really, those are the 2 big issues that he's facing. And so we do our ward round, we talk to him, and you just see this, he's asking, what about the hands? What are we going to do about the bladder? What's the treatment? Because your whole life you've been told that if there's a problem, you can fix it. And now he's 91, and there are these 2 problems. And you know what? With this kind of canal stenosis, if he was 60, we would call neurosurge and they would cut in. But he's not 60, he's 91, and the procedure has risks that outweigh the benefits. And so, you just kind of say, "I'm sorry, there's nothing we can do about that." And then you just look at his face, just come to this sense of realization that, and he says that's That's age, I suppose, which is quite sad. And what's sadder still is that when he doesn't have any next of kin, no family, no kids, no friends, we asked him, is there anyone you want to call? It's just the pub manager really that he's in touch with, but there's no one else. And so he's not, in a sense, and this is my kind of personal interpretation, he doesn't seem like he's living anymore. It's more like he's waiting to die, which is a horrible situation to be in. So I guess it's made me, want to call my grandparents and reach out to them and make sure you're staying in touch with them and that kind of thing. I also had to do a neurological exam on him in front of the whole medical team, which is a little bit of like, let's see what you can do. Because neuro exams are just hard because they can last an hour. Like if you did a proper, thorough neurological exam, every cranial nerve, every coordination test, upper and lower limbs and trunk, that's an hour. Especially with interpretation and with a patient that is frail and difficult to move and might not hear well. It's not quick. So on a ward round, you need to be quick. So you need to kind of be targeted and choose your examinations. So the consultant says, do whatever you think is clinically relevant, which means as a student, you need to be switched on. Like, don't do cranial nerves if you think that there's a central canal stenosis, because you want to be testing the nerves from the spinal cord, not the cranial nerves. So did the upper and lower limbs and had pretty interesting findings. He had C5 dermatome, not loss of sensation grossly, but definitely loss of fine touch and temperature. He also had brisk reflexes. Interestingly, I didn't see any signs that he was hypotonic or weak. He actually was pretty strong, which is strange because you expect that with a cord compression, that at the level of the compression you have lower motor neuron signs, and below that you have upper motor neuron signs. So the compression wasn't so significant that it was giving that kind of classical history, and that happens all the time. But we had imaging to confirm that he did have compression in multiple places. There's about 20 patients per consultant, and as the junior doctor team usually works for about 2 consultants. So maybe not 20 patients, maybe 15. So we had about 30 patients on our kind of first ward round. So it's busy. And this is a really good time to point out the importance of allied health. Geriatrics would be so bad if it did not have allied health, because allied health includes social workers, occupational therapists, physiotherapists, and nurses. And they're literally the ones. The nurses are monitoring for any kind of new delirium, confusion, problems that are acute, because they see the patient the most. Social work is getting all the services in, cleaning, cooking, shopping, etc. Occupational therapy is checking that the mobility that the patient has is safe with respect to their home. So if they need a rail, that's occupational therapy. And physiotherapy is getting them moving, getting them mobile if possible, but also making the assessment that maybe they actually can't be independent anymore with what's called the activities of daily living. So the activities of daily living is like brushing your teeth, transferring from a bed to a chair, these kinds of things. So I've really come to be appreciative and grateful to the allied health, and I think you just have to be. Like, there are sometimes doctors who kind of, they see healthcare as a hierarchy, and it's true that there's a lot of hierarchical things in healthcare, such as the team structures, but we're all on the same team. We're all trying to do what's best for the patient, and we just got to respect each other and be grateful to one another. Gratitude is the cheapest way to be happy. All you have to be is grateful, and life is better. So anyway, that's a little bit about the ward round. After the ward round, you do a paper round where the team talks about, you know, all the different jobs that are outstanding. So maybe you need to call a GP. I had to call a nursing home, whatever. Sometimes you need to do bloods. Yeah, it's also really interesting, guys. Like, you have to think about ethical considerations often. Like, what's the ethics around them consenting to a procedure? Do they have autonomy? Do they have capacity to understand the consequences of the decisions? If they're in an acute state of delirium, they're not, right? If they're confused. Certainly in advanced dementia, they're not, but maybe in early dementia, they are. So you have to do a lot of cognitive assessments as well. Anyway, that's it, guys. I'll see you in the next video.